about gestational diabetes. سيسلط الضوء على السكر والهيبرغليسيميا during pregnancy, how to deal with. تفضل بروف
بسم
محمد.
الله الرحمن الرحيم. شكرا على التقديم الجميل. في شرعنا في السكر قد جاءني الضيف الثقيل المفتري، هذا الذي أسموه زورا سكري، إذ ليس حلوا طعمه بل أنه العلقمي الحنظلي المرمري، فلقد حرمت من اللذائذ كلها وحرمت حتى من شهي المنظر. Gestational diabetes, by the way, gestational diabetes is a carbohydrate intolerance that begin or diagnosed for first time during pregnancy. The diagnostic category of gestational diabetes, there is gestational diabetes A1, and this is usually treated mainly by lifestyle intervention. The second type is A2, and this requires a pharmacological treatment to control the blood sugar. 15% of gestational diabetes will become diabetes after delivery, usually type 2, while 50 to 60% will develop diabetes after 5 to 10 years. The prevalence of gestational diabetes is usually about 5%. What about the risk factor for diabetes? The first one is called very high risk factor. Are those women with severe obesity? Are those women with previous history of gestational diabetes? Are those who delivered a large-sized baby? Are those with glycosuria? Are those with polycystic ovarian syndrome? Those with a positive family history? While the low risk group are women whose age is under 25 years old, her weight is normal prior to pregnancy, there is no diabetic in the first or second degree relative, there is no history of impaired glucose tolerance, and there is low risk of ethnic variation. What is the diabetic effect of pregnancy? During pregnancy, there is an insulin resistance together with the beta cell, some sorts of beta cell dysfunction. Insulin resistance is due to the many hormones, including the human placenta lactogen, including the estrogen and the progesterone and the cortisol. Also the role of the cytokinase, including the tumor necrosis factor alpha. Also there is a destruction of the insulin by the placenta and by the kidney. Also there is increased lipolysis, there is impaired or changes in the glyconeogenesis. Also there is some source of beta cell dysfunction. What is the clinical feature of diabetes or gestational diabetes? The same as diabetic with the characteristic classic triad, as you know, polyuria and polydipsia and weight loss. There is also blurring of vision, there is infection in the bladder and the vagina and the skin. How to diagnose a gestational diabetes? If the patient is clinically symptomatic, if the patient came to you with a symptom, you have to order for the fasting blood sugar, for the random blood sugar, and for oral glucose tolerance test. It's better to avoid hemoglobin A1C because HbA1c usually capture the chronic hyperglycemia, and the gestational diabetes is an acute presentation, so the A1C may be normal at the time of presentation. World Health Health Organization diagnosis if one or more of the following criteria are met. The fasting blood sugar ranges from 5.1 to 6.1 millimole per liter. 1 hour blood glucose more than 10 millimole, or 2 hour blood glucose from 8.5 to 10 millimole per liter. What about asymptomatic patient? Patient with gestational, she is asymptomatic. The NICE and World Health Organization recommended a screening test for gestational diabetes by using one-step or two-step oral glucose tolerance test. When we are going to do the screening test, what is the time of doing the screening test? In the first visit in a woman with high risk factor for gestational diabetes, or at 16 to 18 weeks of gestation in a woman with previous history of gestational diabetes, or at 24 to 28 weeks of gestation in those with medium or low risk for diabetes. So there are two steps, your one-step and two-step test for diagnosis of gestational diabetes, one and two-step strategy for diagnosis of gestational diabetes. The one-step strategy, usually they perform your 75 gram oral glucose tolerance test with the plasma glucose measurement when the patient is fasting and after 1 and 2 hours. Usually at 24 to 48 weeks of 24 to 48 weeks of gestation, if the woman is not previously diagnosed with overt diabetes, you have to ask the patient to fast for at least 8 hours or more. Then you have to check fasting blood sugar. If it is the diagnosis with the blood sugar level meets or exceed fasting to 92 milligram per deciliter, 1 hour postprandial 180 milligram, and 2 hour postprandial 1 hour post-oral glucose tolerance test 153 milligram per deciliter. The two-step diagnostic strategy. Step 1, usually you have to perform a 50 gram non-fasting glucose load test. There is no need for fasting. You have to give the woman about 50 gram glucose and you have to check the blood sugar after 1 hour. If the blood sugar after 1 hour is more than 240 milligram, you have to proceed to 100 gram oral glucose tolerance test. This is the step 2. يبقى step 2 100 gram oral glucose tolerance test while the patient in a fasting. The diagnosis is made with more than 2 blood glucose level more or exceed the fasting أكثر من 95, 1 hour أكثر من 180 milligram per deciliter, 2 hour more than 155 milligram per deciliter, 3 hour more than 140 milligram per deciliter. What is the pathogenesis of complication of gestational diabetes? As we know that there is a risk factor, for example, increasing in the cortisol, growth hormone, progesterone, and placenta-lactogen. This leads to increased hepatic glucose and increasing free fatty acid, which leads to gestational diabetes. Insufficient insulin secretion and insulin resistance also cause gestational diabetes. Obesity and lack of exercise or unhealthy diet, they cause gestational diabetes. Gestational diabetes will affect the fetus and also have an effect effect in the mother. Effect in the fetus is due to increased glucose and increasing free fatty acid. This leads to increased fat amounts and hyperinsulinemia. This leads to neonatal hypoglycemia and obesity and diabetes in baby and children. Also, gestational diabetes leads to increased oxygen uptake, increased oxidative stress, increased fetal substrate, increased delayed organ maturity, and increased endothelial dysfunction. This leads to polycythemia, neonatal asphyxia, stillbirth, shoulder dystocia, respiratory distress problem, microsomia, and other birth problem, the dysmorphogenesis. In the mother, there is a spontaneous abortion, hypertension, cesarean section delivery, gestational diabetes recurrence, and increasing risk of type 2 diabetes, retinopathy, nephropathy, and ketoacidosis. So this is the complication. What's the treatment guideline? According to the NICE guideline, the treatment target in the preprandial blood glucose should be from 63 to 106 milligram per deciliter. 1 hour postprandial should be less than 140 milligram per deciliter. According to the ADA guideline, the preprandial should be less than 95 milligram per deciliter plus either 1 hour postprandial less than 140 or 2 hour postprandial less than 120. This is in a woman with gestational diabetes. While in a woman, she is already known to have type 1 or type 2 diabetes, and she gets pregnant, and according to the ADA guideline, the goal for the treatment, if it is good, can be reached without significant hypoglycemia. The pre-meal and the bedtime and the overnight glucose should be 60 to 99 milligram per deciliter, while the peak postprandial from 100 to 129, and the hemoglobin A1C should be less than 6. So, this is the same, but what I want to comment in at the 2 a.m. to 6 a.m. the blood sugar should be more than 60, and the patient should be insisted to check her blood sugar at this time at least weekly, because this is a very serious period. It is called insulin sensitive period, because during this period the only hormone to work is insulin. There is no other hormone to work, and you know that insulin is a hypoglycemic hormone. So if the peak of action of insulin occurs at this period, the patient may develop severe hypoglycemia and may die in bed. As Professor Zaid said, this is called death in bed. This is the very serious side effect of the use of insulin therapy. Treatment types, as we know, a physical activity, as they say, at least walking 30 minutes or more, 5 times a day per week. The medical nutrition therapy, the majority of the gestational diabetic women are obese, so there should be a caloric restriction at least 30 to 30.35% kilocalorie per kilogram. The treatment types, carbohydrates should account for 40 to 50 of the total calories. You have to use a complex carbohydrate. You have to use a carbohydrate that contain a high fiber content. You you have to use a carbohydrate of low glycemic index. بروتين 20%، فات 30 إلى 40%، less than 10% should be saturated. The pharmacological treatment. When we start a treatment, they said you have immediately starting pharmacological treatment if the patient presents with severe hyperglycemia and the fasting blood sugar is more than 125 postprandial, more than 200 milligram per deciliter. The Canadian Diabetic Association and the NICE Association recommended that you have to start pharmacological treatment if the lifestyle intervention fail to achieve a glycemic target within 1 to 2 weeks, or if the ultrasound shows a fetal macrosomia, so you have start pharmacological. What's the types of pharmacological treatment? We have insulin, metformin, and glyburide. The majority of recommendation is with insulin, especially ADL, Food and Drug Administration. They prefer only insulin while other is not. But when we use metformin, the metformin is used when the patient refuse insulin. The patient refuse insulin or the insulin cannot be used safely. The insulin cannot be used safely. What's the mechanism of action? As you know, what is the benefit? طبعا الميتفورمين it overcome insulin resistance. الميتفورمين decrease body weight. الميتفورمين does not or it has no risk of hypoglycemia. الميتفورمين is very benefit, particularly in a pregnant woman with polycystic ovary syndrome. يبقى very effective. The adverse effect ممكن يعمل preterm delivery, contraindication, as you know. Where is can I do? This is the many studies that some of them are with use of metformin and other are against the use of metformin. What about the glyburide? The glyburide can be used as a third line treatment. If the patient refuse insulin and the patient cannot tolerate metformin, or metformin is contraindicated, or the patient does not reach a glycemic target with metformin, we can use a glyburide. So the best drug up till now for the treatment of gestational diabetes is insulin. So it is the first line therapy. There are two types, as you know, of insulin. There is a human insulin and insulin analogs. Human insulin, either your rapid acting, your act rapid, or intermediate acting, your MPH, while the insulin analog also there is aspart and lispro and long-acting analog, the glargine and detomers. What is the difference between the two? They say that the insulin analog has low risk of hypoglycemia. They have immediate action after injection. Yani the onset of action is immediate. Some of them, especially the long-acting, are peakless, so there is no risk of hypoglycemia. But they say that the insulin, aspart and glargine may have some teratogenic effect, so it's better not to be used. Detamer is bitter and the lispro is bitters. What is the treatment regimen? If the patient is present only with fasting hyperglycemia, you have to start with basal insulin only. If the patient present with both fasting and postprandial hyperglycemia, you have to use the basal bolus insulin regimen. What is the dose? In the first trimester, is 0.7 international unit per kilogram per day. In the second trimester is 0.8. Majority of recommendation is with insulin, especially ADL, Food and Drug Administration. They prefer only insulin while other is not. But when we use metformin, the metformin is used when the patient refuse insulin. The patient refuse insulin, or the insulin cannot be used safely. The insulin cannot be used safely. What's the mechanism of action? As you know, what is the benefit? طبعا الميتفورمين it overcome insulin resistance. الميتفورمين decrease body weight. الميتفورمين does not, or it has no risk of hypoglycemia. Metformin is very benefit, particularly in a pregnant woman with polycystic ovary syndrome. يبقى very effective. The adverse effect ممكن يعمل preterm delivery, contraindication, as you know. Where is can I do? This is the many studies that some of them are with use of metformin and others are against the use of metformin. What about the glyburide? The glyburide can be used as a third line treatment. If the patient refuse insulin and the patient cannot tolerate metformin, or metformin is contraindicated, or the patient does not reach a glycemic target with metformin, we can use a glyburide. So the best drug up till now for the treatment of gestational diabetes is insulin. So it is the first line therapy. There are two types, as you know, of insulin. There is a human insulin and insulin analogs. Human insulin, either rapid acting, act rapid, or intermediate acting, MPH, while the insulin analog also there is aspart and lispro, and long acting analog, the glargine and detomers. What is the difference between the two? They say that the insulin analog has low risk of hypoglycemia. They have immediate action after injection. Yani the onset of action is immediate. Some of them, especially the long-acting, are peakless, so there is no risk of hypoglycemia. But they say that the insulin, aspart and glargine may have some teratogenic effect, so it's better not to be used. Detamer is better, and the lispro is better. What is the treatment regimen? If the patient is present only with fasting hyperglycemia, you have to start with basal insulin only. If the patient present with both fasting and postprandial hyperglycemia, you have to use the basal bolus insulin regimen. What is the dose? In the first trimester is 0.7 international unit per kilogram per day. In the second trimester is 0.8. In the third trimester from 0.9 to 1 unit per kilogram per day. This is what's called basal bolus insulin regime. So you have to calculate the total daily dose of insulin. You have to give 50% as a bolus, usually at the bedtime, and 50 as a basal, and 50% as a bolus divided into 3 meals. So when you use a bolus, you have to monitor the fasting blood sugar. Usually the average fasting blood sugar, if it is more than 90, you have to increase the basal insulin by 2 to 4 units. What about the bolus? You have to monitor 1 or 2 hour postprandial. The average 2 hour postprandial postprandial if it is more than 120 milligram per deciliter, or 1 hour postprandial more than 140 milligram per deciliter. You have to increase the preprandial insulin by 2 to 4 units until the glycemic target is reached. What's the complication of insulin therapy? The maternal complication, usually there is a maternal hypoglycemia. Its prevalence about 20%. How to avoid it? You have to avoid a tight glycemic control or target. Fasting blood sugar should be above 66 milligram per deciliter according to the Canadian Diabetic Association, or above 70 milligram according to the ADA. You have to use insulin analog. As we said, the risk of hypoglycemia is less with the use of insulin analog than with the use of the human insulin. Complication associated, fetal complication associated with insulin therapy. There is a neonatal hypoglycemia and congenital anomaly with the use of Lispro or insulin. So this is what we said, that when the patient is presented for antenatal care, the risk of pre-existing diabetes presents, yes, you have to screen for diabetes using a fasting glucose level or A1C or 2-hour glucose tolerance test. If there is no, you have to screen at 24 to 28 weeks of gestation. If the screening for diabetes is abnormal, you have to manage as pre-existing diabetes. If the screening at 24 to 28 weeks of gestation is normal, you have to do a routine care. If it is abnormal, you have to begin blood glucose self-monitoring with lifestyle modification and close up. The glucose level fasting, this is the target, less than 95 milligram per deciliter, 1 hour postprandial less than 140, 2 hour postprandial less than 120. If it is achieved by lifestyle intervention, you have to continue monitoring. If it is not achieved, you have to start initiation either of oral agents or insulin, and you have to follow up the patient in 1 to 2 weeks. Okay? Glucose control. If the glucose is not controlled, you have to adjust the dose of the insulin, or you have to add other than metformin. If it is controlled, you have to continue treatments. Consider antenatal testing. Maternal antenatal testing, usually at 32 to 34 weeks, if using oral agent or insulin. If the patient has a poor glycemic control despite medication use or another indication for delivery, such as preeclampsia presentis, yes, you have to induce induction of labor as clinically indicated. If no, you have to plan for delivery at more than 39 weeks of gestation. About after delivery, what you are going to do, you have to monitor the children for the development of hypoglycemia, and you have to monitor the mothers for whether she is normal, or she has impaired glucose tolerance, or she has already type 2 diabetes. So this is the indication for your antepartum fetal testing for women with hypertensive disorder or prior stillbirth or suspected macrosomia. Fetal testing should be undertaken. Women in pharmacotherapy with either insulin or oral agent undergo at least weekly fetal testing, that beginning at 32 weeks of gestation. What's the time of delivery? إذا كانت الwoman well controlled with pharmacological therapy at 39 plus minus 6 weeks. And a woman which is well controlled on diet at the 39 plus 0 or 40 plus minus 6. If it is not controlled at all, at 37 plus minus 0 to 38 plus minus 6, after delivery, postpartum screening, usually at 6 to 12 weeks by 75 oral glucose tolerance test. If it is normal, you have to continue screening every 3 years. If the glucose tolerance test is impaired, fasting glucose or impaired glucose tolerance, you have to refer for nutritional therapy and weight loss management. If it is new diagnosed as diabetes, you have to refer for the treatment of diabetes with thank you. Assalamu alaikum.